So I will also try to not keep you from lunch. We're going to now focus on the second category here, the poliposis syndromes, starting with classic FAP and then going down the list to some of these other rare diseases. And I think it's sort of been an interesting area once again over the last few years as we've started to understand these syndromes better. So Lynch syndrome causes about 3 to 5% of all colon cancers. Some of these other syndromes that we're going to talk about probably account for 1 to 2%. So they're quite rare, but I think what we're learning more and more is that they're probably not as rare as we once thought because the phenotypes are very variable. So let's start with a classic disease, though. This is poliposis. All of us learned about this in medical school. We can certainly identify it when we see it without too much difficulty. So in the classic form of poliposis, the penetrance of disease, meaning if you have a gene, what's the likelihood that you're actually going to get the disease is over 90%. In Lynch syndrome, we talked about that that's not always the case. Sometimes people have a gene and they never develop cancer. In classic FAP, that's not the case. We used to talk a lot about Gardner syndrome, and this was the association of poliposis with desmoid tumors, upper GI tract adenomas, thyroid cancers, brain adenomas. Brain tumors. And what we've learned, similar to what Maria said about Crohn's and ulcerative colitis, is that when you understand the biology of these diseases, the underlying pathogenesis is not that different. And clinically, we're often managing these patients quite similarly. So to me, whether a patient has Gardner syndrome or FAP doesn't really matter. Their management is going to be quite similar. All you need to make a diagnosis of FAP is to have a pathologist tell you that you've got multiple adenomas in the colon. And we're going to talk about some of the distinctions between the numbers, but you don't need genetic testing. It's really still a very clinical diagnosis. And as far back as in 1993, we learned that most of these patients have a mutation that they inherit in a gene called APC, which is a classic tumor suppressor gene. So nowadays, you can do a blood test. If you have an affected patient with multiple polyps, you can draw their blood. And in the States, it takes about 4 to 6 weeks to get APC analysis done. And if you identify a mutation, it often actually doesn't change very much for that first patient because you already knew that they had poliposis. What it allows you to do is test other people in that family to see if they carry that same mutation. So the way the genetic testing happens is you do the blood test, you sequence the entire gene, you find the mutation, and it is the same mutation that is passed down to the kids. And so the second sort of genetic test that you'll do in these kids looks for that particular mutation. In this 16-year-old who carries the mutation, you can tell them that they've got a very high likelihood of developing poliposis, almost 100%, as I said. For this 14-year-old who's negative, they have not inherited the disease. So the story is over. They are not going to develop poliposis, and they are not at risk at passing it on to their children. So in this setting, when you have a mutation, it's considered to be a 100% accurate test. Now, this is the new kid on the block. It's MYH. So we knew about FAP. Now you have to know about a diagnosis called MAP, MYH-associated poliposis. This is a gene that's involved in base excision repair. What we know is that there are 2 hotspots, but basically MYH causes a disease that's very similar to FAP. The big difference is that it's autosomal recessive. So in FAP and Lynch syndrome, what happens is that your parent has a mutation. The parent passes that mutation on to the children, and those children have the very elevated risk that we talked about. In MYH, you need to be biallelic, so it functions as the classic autosomal recessive syndrome, and it's only the biallelic mutation carriers that actually get the poliposis. They'll get multiple polyps. It looks identical to familial poliposis, but what will be different is that their parents don't have that history. So if you see this kind of patient, so this is a patient with multiple adenomas, they've got an early onset cancer, and there's no family history, don't be assured that that patient doesn't have polyposis. There are many reasons that this can happen. The first one is that this person could have MAP, and the parents are heterozygotes. The second thing is that this patient could be the first one in the family that's developed polyposis, and that happens in about 30% of cases. So the parents don't have the disease, but this individual's children are at 50% risk of inheriting it. In polyposis, you also have to think about other cancer risks, and we're going to talk about how this affects their management. So these patients get upper tract adenomas. So these primarily include duodenal adenomas and ampullary adenomas. They get lots of gastric polyps. So these are fundus gland polyps, but actually the gastric cancer rate is very low in these patients. So one of the big reasons for referrals we get in our clinical practice is that somebody has a carpet of gastric fundus gland polyps, and they've been recommended to undergo total gastrectomy. And that's actually usually the wrong thing to do. They don't get gastric cancer, they just have a lot of polyps. It's the duodenal adenomas and the ampullary polyps that you need to worry about. There's a quite high rate of thyroid cancer, papillary cancers. They get CNS tumors, as I talked about. Children up to the age of 5 are at risk for hepatoblastoma, and then some of these other rarer tumors that they get. So what is the management? Really nothing much has changed in FAP management over the years. Unfortunately, we still need to take people's colons out. So in the classic form, usually in the late teens to early 20s, we're seeing the kids and working with the colorectal surgeons to plan their surgery. And more the surgery is a total proctocolectomy with a J pouch anastomosis. In certain cases that we'll talk about, particularly in people who have milder forms of disease, you can do a subtotal colectomy. And if once you do that, you still need to monitor them for the rest of their lives because they can form adenomas in the pouch or they can form adenomas in the remaining rectum. So annual surveillance, looking for adenomas and removing them. Upper tract surveillance for these duodenal polyps should be done every 1 to 3 years. And it's important to know that you need to pass a side viewing scope to look at the ampulla in these patients because that's really where the major cancer risk is. And often we recommend that you should biopsy the ampulla even if it looks endoscopically normal because a lot of these people will have microscopic adenomatous changes. Chemoprevention. So there was a lot of interest in this. Aspirin, Solendec, COX-2 inhibitors were all tried out in the polyposis patient population. And what we learned from those studies was that these drugs are effective, but they're effective only at about 30%. So you can reduce polyp formation by about 30%. You can prevent new polyps from forming, but there's certainly not enough to change the cancer risk in these patients. And there was a small study done in the pediatric population trying to delay colectomy in polyposis patients that was negative. And just so you know, there's a large multi-centers trial that has just started in the last month or so that's going to look at a combination of Solendec and DFMO as primary prevention in these patients. So we may have something in a few years, but it's not there now. And then all patients who have polyposis are recommended to go some sort of thyroid cancer screening, either by physical exam or by annual thyroid ultrasound. Now, attenuated FAP, this is probably, the FAP is a rare disease. You may not see very much of it in your practice, but what we're realizing is that attenuated forms of the disease are much more common than previously appreciated. So this is when you have many polyps. They can be dozens, less than 100. And the patient that you need to pay attention to in this case are the ones that you do a colonoscopy and you find 5 polyps. And you bring them back and they have another 5 polyps. And you bring them back and they have another 5 polyps. Those people, as you add up these adenomas, may have a form of attenuated polyposis. So it's characterized by later onset and by fewer polyps. There's a wide spectrum of risk, but the risk is probably as high as 60 to 80%. It just occurs later on in life. So the big issue with these people is that they need to be followed much more closely than your average sporadic patients. You can avoid colectomy by close surveillance, but probably, again, every 5-year surveillance, and this subset of patients isn't the right thing to do. And the underlying genetics are the same as the classic FAP. So MYH mutations, either recessive or APC mutations. Now, what about management of attenuated polyposis? So you have to think about the same organ systems that we talked about, the colon, the upper GI tract, the thyroid cancer risk. Colonoscopy can start later. So if you have a family where you've got 50 adenomas, you don't need to start in the late teens. You can start colonoscopy at age 25 to 30. Annual colonoscopy, as I said, with removal of polyps is really the mainstay of treatment. And the decision to sort of pull the trigger to go to surgery is based on the number of polyps in the colon. So it's really based on the gastroenterologist's assessment of, can I keep ahead of these polyps? Can I take them all out? Or am I putting the patient at risk by leaving their colon in? And more, I think we're getting more comfortable with sort of a watchful waiting approach on these patients. If you need to go to surgery, often we can do subtotal colectomy in these patients and sort of prevent the postoperative morbidity that are associated with the pouch. And once you do that, you still need to check for upper tract surveillance for the duodenal and ampullary adenomas. And as I said, the thyroid cancer risk is still relevant. Now, how common is this? And I'm going to present to you just a paper that looked at a large cohort of patients that underwent genetic testing, where we looked at thousands of patients and divided them based on the number of polyps that they had. So we had, a small number of patients with classic thousands of polyps, over 1,000 patients with 100 to 999 polyps, and then a big group of this attenuated polyposis phenotype. And what is clear is that if you get sort of this classic form, as I said, about 80% of them, you'll find these mutations in APC. A small component of them have this autosomal recessive MAP syndrome. As you have fewer polyps, the APC mutation rates goes lower, and the MAP rate goes higher. And then what's really interesting is that in this 20 to 99 polyps, or even in the 10 to 19 adenoma polyps, there is a significant rate of attenuated polyposis. So again, think about this as you think about patients with multiple adenomas, that they may actually have a genetic disease that had previously gone unrecognized. So 10 polyps has become sort of the trigger point to think about polyposis. And when you see any of these other associated features, think about attenuated FAP as well. Now, this is interestingly what's new in FAP, sort of brave new world kind of thinking. You can actually do prenatal testing for genetic risk now that you have defined genes. And this has been thought about for loss of genetic disease for a long period of time. The options include amniocentesis and CVS, but most patients don't want to consider those options in this kind of adult onset disease. But prenatal genetic or preimplantation genetic diagnosis is something that is being considered for these highly penetrant syndromes. So this is an embryo. It's a 8-cell stage embryo. And what you can do is actually aspirate a single cell from that embryo that's created through in vitro fertilization. You can test that embryo for the APC mutation and only implant the embryos that are negative for the APC mutation. This is something, that is actually being used by patients in FAP and some of these highly penetrant families around the world, I think. So it's, again, nothing that we advocate for patients, but for people who are their childbearing ages who've had very, very high morbidity in their families, it's something to consider. So moving on to this thing, I'm just going to spend a couple of minutes on the hamartomatous polyposis syndromes. So here was the adenomatous polyposis. Here's the hamartomatous. Peutz-Jeghers syndrome, rare disease. I think this is sort of for the people who are studying for exams. The mucocutaneous pigmentation is classic. The pathologist can tell you that there's a Peutz-Jeghers type polyp. And really the thinking now is that even if you see one Peutz-Jeghers type polyp, you should be thinking about this syndrome. And the important thing is that their cancer risks are really high. So some of the recent papers show that these patients have a 90% risk of developing some kind of cancer throughout their life. And again, they're not all GI tract tumors. So the big one is breast cancer. So if you're seeing a Peutz-Jeghers patient, that person needs specialized screening for breast cancer. Very high rates of pancreatic cancer, small intestinal cancers, and again, gynecologic tumors. Juvenile polyposis syndrome, there are 2 genes now that have been associated. The diagnosis should be considered if you see more than 5 juvenile polyps. So in the pediatric setting, we quite often see juvenile polyps, and they're not uncommon. But in the adult population, if you're seeing a lot of juvenile polyps, then you should think about the syndrome. And again, there's lots of cancer risk, mainly colorectal cancer, high rate, 50% lifetime risk, gastric cancer rates of about 20%, as well as small intestinal cancers. So if you see a patient with colon cancer or even a patient with multiple polyps, this is the approach. So get a detailed family history. Think about age of onset. So the big sort of cutoff feature in colon cancer is age 50. Under age 50 is really unusual for GI cancers. Quantify number of polyps. So as I said, more than 10 polyps should start you thinking about genetics. Scope these people from above. So if you're seeing multiple colorectal adenomas, look in their upper GI tract and see what you're finding up there. Look at the ampulla very carefully. Define size and location of polyps. Get a GI pathologist to define the polyps, because sometimes we actually get changes in the diagnosis based on a specialized pathologist review, and then think about genetic evaluation and management based on the results. Couple of words on hereditary gastric cancer. So I know you see a lot of gastric cancer. There's a small component of families who have inherited forms of gastric cancer, and very high lifetime risks of greater than 60%. The important part is that there are multiple studies now that show that screening is ineffective in these patients because they're getting diffuse cancers that are submucosal. So you can biopsy as many biopsies as you want. You can take 20 biopsies, you can take deep biopsies, and you're not going to find the cancers. And there's a classic paper in the New England Journal now that showed that if you take families or patients from these families to gastrectomy, you get multifocal gastric cancers that are submucosal. So if you have a family like this, really the right recommendation is prophylactic gastrectomy. So again, rare, but important to think about if you see them. And these families, for some reason, have an increased rate of lobular breast cancer. So again, think of gastric and breast cancer together. And the times that you should think about this is when you get young onset diffuse gastric cancer or more than one diffuse gastric cancer in a family. Really think about whether this could be a genetic disease and whether you need to be more aggressive with that family. So GI cancers in the genetics era, to summarize, the bottom line is that we're still dependent on personal and family history as our screening tool. The big sort of era of full-scale genetic analysis for all of us is still a few years down the road, and we're really still based on family history assessment. The hallmark features that you should be paying attention to is early age of onset of cancer or polyps, rare histologies. So something that you're not used to seeing regularly should strike a bell in terms of genetic disease, and multiple relatives affected relatives in the family. We need to systematize family history assessments in clinical practice. So I think we don't do a great job at identifying these patients because we're so used to and so busy with taking care of the patients. And whether it's by having patients fill out a family history before they come in to see us, or having our nurses or the adjunct staff do some of these assessments before we see them, is really where we need to go. Computerized systems of getting family history, et cetera. Think about referring for genetic counseling and testing when necessary. And I really think that this is really what's going to change over the next few years, that the spectrum of genetic diseases that we're seeing is increasing. So I didn't have time to talk about serrated polyposis or mixed polyposis. And I'm sure all of you are seeing more and more serrated polyps. You're seeing more and more polyps of mixed histologies. Those patients clearly probably have genetic disease. We just haven't identified which gene there are, and we haven't really studied them very carefully yet. So the whole spectrum or the whole landscape of this is going to continue to evolve over the next few years. So stay tuned and pay attention to some of these sort of features that hopefully you've learned over the last couple of hours. Thank you.